everyone, and welcome to the Surgical Ergonomics Podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loupes that are built for you. Q Optics is more than magnification. Custom crafted through the lens loupes engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive TrueFit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized stress-free fit and all-day comfort. The Ergo Direct Vision loupes with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loupes for a straight-ahead gaze and complete ergonomic relief. And with crisp edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q Optics, designed for comfort, built for performance. By the way, Q Optics has also provided us with an Ergo Angle Deflection loupes and headlight combo giveaway. The details will be provided at the end of this episode, so stay tuned. Hello, everyone, and welcome to another episode of the Surgical Ergonomics Podcast. Today, I am excited to have as our guest Dr. Erin Sheffield. She's a board-certified oral maxillofacial surgeon, speaker, educator, and advocate. Dr. Sheffield practices at Quincy Medical Group, a large multidisciplinary physicians group in Illinois. She previously served as an assistant professor at the University of Iowa and currently serves on her institution's committees for antibiotic, stewardship, and ambulatory surgery. Her big passion is reshaping the culture of surgery by amplifying the voices of women and redefining what it means to thrive in this high-demand profession. She is the founder of The Doctor Is All In, formerly known as Elevate Summit, a wellness and leadership retreat for women in OMFS, and she's co-host of the Resting Stitch Face podcast, where she leads unfiltered conversations about the realities of life as a woman in surgery. As a content creator, she is known for her openness and authenticity, inspiring the next generation of doctors and empowering patients to make more informed and empowered healthcare choices. Just from this introduction, I am super pumped to have you on the podcast today, Erin, all about unfiltered and authentic conversations about culture and surgery. It's a match made in heaven.
Yes, I'm so excited to have this conversation with you. Thank you for having me.
Well, thank you again for being here. And I should let our listeners know that I've actually known Dr. Sheffield for, I think, the better part of maybe 14 years now. I remember I got my first grant KO8 award in 2011, and she was actually rotating as a second-year OMFS resident on our endocrine surgery service. And she was with me in clinic, and we were kind of celebrating my having gotten the grant and things like that. So we've stayed in touch, even though that was the only rotation she did with us. And then I've been so excited and pleased to follow her journey on social media and to have her here today. So, Erin, tell me now, we heard a little bit about where you work right now and where you started at the University of Iowa, but I was wondering if you could give our listeners a general sense of sort of your childhood, where you grew up, where you trained, and then how you landed up in your current role.
Yeah. Well, first, I want to say I'm so excited to talk to you. You were one of those impactful mentors during residency, and I was even talking about you just the other day to a staff member, and it was probably the same day you contacted me about being on the podcast. So it
Oh,
was very interesting. I remember you were directing us doing some breast exams, and you were telling me, I don't always make the oral surgery residents do this, but since you're a female, I think it's helpful for, someone in your life is going to come and ask you about this. And I kind of laughed and like, oh, yeah, sure. And then sure enough, someone was talking about it. And I was like, well, Dr. Lowell taught me how to do a breast exam. And so if you want, I could take a look. So you ended up being
wow.
correct. I definitely have a lot of memories working with you. And you were really great about taking, this lowly dental resident under your wing. So thank you for that.
Hardly lowly, I'd say.
But I am from Utah
Okay.
originally. I went to Brigham Young University for undergrad, and then I came to University of Iowa for dental school. During dental school, I knew I loved surgery, but I was a fainter, so I didn't know if I would make it on my journey to be a surgeon.
I see. Wow.
Thankfully, the staff there were very supportive and they didn't make a big deal about it at all. And so they encouraged me to continue anyway. And so I did. And I do have to admit, I did pass out my first day of internship in the operating room, but have made it through pretty unscathed since then.
Well, I think all of us in surgery have done, that kind of story. I wouldn't have called myself a fainter, but there was a time during intern year where after like a week of one and two calls, skipping breakfast and landing up I remember it was like a lung resection with the attending, on the week that the senior resident is out of town. I think the attending recognized it before I did and had someone slide a stool under me so that I kind of sat down easily rather than like falling to the floor. So I don't think
Right,
that's anything to be, as you said, worried about or worry about sort of being scathed. I think that's kind of a rite of passage. We all have our moments, training is
right.
brutal. We all have our moments. So, Erin, I'm going to change directions a little bit and actually delve into the ergonomics piece here. But before I do, I want to sort of let our listeners in on something they may not have heard me mention before, which is that when I was undergoing physical therapy for my sort of MSK issues, I've talked about my jaw pain and my neck pain, etc. I was working with Barbara Van Gorp, one of the physical therapists who was working kind of with me, and I was having a tough time with some of the exercises that she was doing with me. And I said, I don't know why they don't tell us this when we express an interest in surgery, that it's so physically demanding and you can get injured. And she said, I don't know why, because the dentistry school here has me come, yearly and give, a lecture every 6 months. They talk about ergonomics. And that's kind of where that idea of an ergonomics curriculum kind of came into my head. And then one thing led to another. I was delighted personally to have you today on the podcast, but this is the other reason I wanted to, have you here is it sounds like dentistry was thinking about this way before us in sort of general surgery or other surgical specialties were thinking about this. So, could you share with us what your ergonomics training was like during your DDS? And then did that continue during OMFS, or did you notice a difference between the attention that was paid to ergonomics during your DDS training versus then when you were training in a surgical subspecialty?
Yeah, I think that's such an interesting question. And I think it really is a big part of the culture of dentistry. I'm trying to remember if we specifically had many lectures on it. I think we had at least a couple,
Yeah.
but it was definitely part of the clinical focus when you get into the clinic. If you were straining or leaning too much, the professor would come and, remind you to try to sit up straight and all of that. So I think they did a good job of trying to incorporate that in. Now, whether we all actually do it. You know, I've
Yeah.
gone through physical therapy as well, and a big part of it is realizing the body wants to do the easiest thing, and it might be a harmful thing, but in the moment, it's going to try to choose that simple maneuver. And so sometimes, we lean into our weaknesses and can cause injury, etc. And I remember even maybe first or second year of residency, my left elbow was just starting to get really sore, and I was getting concerned, how can we continue practicing? I'm,
Right.
I'm, just, I'm haven't even started my career yet, and I'm already having trouble. Is this going to be a
Yeah.
problem? And
Yeah.
even just holding someone's cheek back,
Yeah.
retracting, that's
Yeah.
enough. It's just a cheek. It's not even like a leg, or a big belly or something. It's just a cheek is enough to like be giving me like tennis elbow or something. And then I remember it was very kind of scary to me. My first job outside of residency, they threw a little open house to meet some of the dentists in the area, the referring doctors. And as we were talking, they were all talking about like, oh yeah, I just had my neck surgery, and oh, and I had my
Wow.
neck surgery, and like, yeah, my neck surgery, and oh, my neck needs surgery. It was shocking enough how many people were joining in that conversation that I was like, what am I getting myself into? So
Mm.
I think it's a much more a part of the culture just because I think dentistry in general is so hard on the body that it has to be. We cannot continue to do this year in, year out. I think we're really bending over and doing even more than, most surgeons probably typically are. And so that's just a big focus if they want us in the workforce. We've got to start implementing these things early.
Right. So, thank you for sharing that. So, it sounds like at least there was some awareness raised during your dentistry years, your DDS years. And it sounds like it continued during your OMFS residency. They would at least, even if there wasn't
Mhm.
like a formal curriculum
Right.
or things like that, people were paying attention and telling you, don't do this, this is why it's going to hurt, and telling you
Mhm.
about their own injuries. So I think we, in the other specialties like general surgery, I can only speak for mine, but I think it applies to like otolaryngology, general, gynecology, urology, etc. We don't we during my training, my ergonomics sort of curriculum was probably like, what are you doing? Can you smell the incision? Stand up straight for God's sake. That was ergonomics
Right.
training, right? So how, I guess, you were at the university, then you've gone into private practice. How do you kind of talk to other people, like maybe your staff, your trainees, about ergonomics and best practices? And do you share some of the things that now you have incorporated? You've been in practice for 10 plus years now. What are some of the things that you do?
Yeah, it's tricky when you get new staff, and especially if they haven't been trained in dental and I'm training them on the fly. They don't know these things, and I find they're really straining. We're looking in a deep, dark hole, a small,
Yeah.
deep, dark hole.
Oh, yeah.
And so positioning is really important, making sure that you've got your chair at the right height, etc. And there are different kinds of chairs that are more ergonomic, things like that help a lot. Um, I thought it was interesting in my residency, one of the doctors was very concerned about ergonomics, and so she actually kind of implemented a culture of sitting during clinical surgeries. And I still do that. I still sit in most of my cases, which is very unusual as an oral maxillofacial surgeon. The standard would be to sit or to stand. And it took a little bit of getting used to get the leverage and the center of gravity and all of that for like taking out teeth and doing things as kind of physical work. But that has helped. But I think about that a lot, and I try to kind of change it up. If it's a longer case, I might sit down. If it's a more simple one, I might stand up just so I'm changing the position of my body. So I'm not doing those same things all the time. I know my physical therapist talks about, certain things that I can do to kind of reset my core and my pelvic floor and all those things when I'm between patients. Like when you're sitting in your chair typing, Erin, make sure you hold this position, or here are some stretches you can do. And it's a pain to do, right? Who wants to take time to do some of that stuff? But it's really an investment in yourself. And then encouraging the staff, it's easier to just let them. be doing, this crazy stretching weird stuff, but I try to encourage them. The other thing I would say earlier on in my career, I was much more willing to sacrifice my body for the patient.
Hmm.
So it's tricky. They come in, and a lot of it has to do with anxiety, but we've all been in the dental chair, and usually you have to lay back. And we start taking people back, and sometimes they hardly go back an inch, and they're going, whoa, 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 what are you doing? Do we really have to go that far back? And so I used to be a lot more accommodating, so maybe I was nicer, but it was like, oh, okay, sorry, So unless they really like have a kyphosis or
Hmm.
something where
Hmm.
they really
Hmm.
can't move, I literally will have to like turn my head upside down, like completely
Yeah,
flip up
exactly.
upside down to look inside their mouth if they're not in the right position. And they'll be like, yeah, it hurts my back to go back. And it's like, well, it hurts mine too. So,
Right.
I mean, it's kind of hard. I want to accommodate patients, but, I'm much more like, well, this could be pretty quick. Can we make it work? Or can we kind of split the difference? Or I had a woman come in the other day, couldn't move her out of her wheelchair and a simple extraction. And I thought, oh, I could probably just get it. I could probably just get it. And then I was
And
like,
and then and afterwards you paid for it, let me
right.
guess.
And I was like,
Yeah.
but if I can, well, I'm learning my lesson. I was like, if I can't just quickly wiggle out with the forceps and I'm getting the drill, I'm gonna be upside down and that's gonna be terrible for both of us. So like, we're gonna have to get you back on a day that they can bring you
A
the reclining
stretcher or
chair.
something. Yeah. Yeah.
Exactly. So I'm trying to set personal boundaries with patients because, you know, I don't want to hurt your back, but it's also me and my lifetime of work doing this over and over again, hurting my back. I can't provide the care if I'm on the disability.
Right, 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 right. So, wow, there's a lot to think about and unpack in all the things that you just said. So I'm going to try and do that a little bit for myself and for our listeners. So, for our listeners, if this is the first time you are tuning into this podcast, let me say that what you've heard Dr. Sheffield talk about as her sort of practices for good ergonomic health and maintaining her physical well-being to stay in practice really applies to every single program or specialty you might be in. You don't have to sit here and say, well, Dr. Sheffield is a dentist. I mean, I'm not a dentist. This doesn't apply to me. It actually does. So, what she outlined are things that you can do on a daily basis if you just focus your attention on them. So, the first thing is figuring out how you're going to position the patient and your equipment so that you are not in non-neutral postures, right? Going like this, trying to peek into a cavity, will bring the chair up, recline the patient back. In our cases, we may have to, position the head, turn the table, whatever.
Mhm.
But positioning is key, right? Preparation is half the battle. So you've got to be able to do that. And then you have to have an awareness of your own postures. Because if you notice yourself doing something that's hurting or you're starting to feel twinges, that means it's non-neutral and you need to stop and do something differently. And we'll get to one of those things, which is maybe perhaps you need to just straighten up and take a break and stretch. I think what people forget is, like you said, well, it's only a couple of minutes. I mean, maybe I could get her back and just pull the tooth out. It's just a little numbing and then pull the tooth out. But what we don't think about is that short durations of non-neutral postures multiplied by the entire day, multiplied by the cases you do in a week, multiplied by the, X number of weeks you work in a year over a lifetime or a 10-year career, will cause significant damage and lead to degenerative disc disease, particularly in the C spine and the L spine. For dentists and OMFS, it's in the C spine, as you heard from Dr. Sheffield.
Mhm.
And actually, the literature supports that if you've been in practice for more than 10 years as an OMFS, you're 2.5 times more likely to have injury than if you were in the first, 10 years. So listen to what she said about positioning and postural awareness and resetting. So this brings me to a couple of things. One is, this thing about breaks. We're always sort of advocating for breaks as a great ergonomic intervention. And some people say, well, my case is so short, I don't really feel like I should take a break. So I want to hear what your thoughts are on the procedures you do and whether you find breaks are important or not, and then whether you do some stretches during the breaks. And then I want to talk about our adjuncts, those things like loops and microscopes.
Yeah, I mean, luckily for me, most of my cases are pretty short.
Okay.
If we're getting past 2 hours, at least in
In
my
your
clinic,
office? Yeah.
yes, then that's a surprise. But I do notice you get so focused. And
Hmm.
then at the end, when you stand up, you're like, oh, ooh, you got a crick in your back or something that you didn't realize. So it's definitely something to be cognizant of. And even those shorter cases, as you do more and more, starts catching up to you. So
Yeah.
I try to do the stretching. And I also think about just when I'm sitting, engaging my pelvic floor, engaging my core, making sure that
Hmm.
I'm in the neutral position that my physical therapist has, asked me to be, making sure my lighting is great so that I can see and I'm not like putting my head closer than it has to be. I don't like to use a headlight or
Okay.
I kind of gave up my loops after dental school, which is probably dumb. And as I'm getting older, I probably need to go back to them. When we were working on like micromillimeter level of detail, going to
Yeah. Yeah.
meter or centimeter, I just felt like I didn't quite need that so much. But I don't like that extra weight on my
Hmm.
head.
Hmm.
That
Hmm.
to me causes pain and discomfort too. So I invested in like heavy duty OR quality lights, not just like dental lights, so that I can see better and I can offload some of that off of me. So anything that I can do to not be carrying extra weight, extra strain,
Right.
etc., has been really helpful and important. And then, dentists usually only most dentists work 4 days a week.
Hmm.
And I think the big part of that is just your body can't take it. So I only work three
Interesting
days a
point.
week.
Hmm.
I work 3 days a week, and part of that is because I got a lot of other stuff that I'm trying to do with my kids or my
Yes,
side
yes.
businesses. But some of that too is purposeful. Like my body does a lot better when I have a break and I'm not doing it day after day after day. I think that makes a big difference. So I'm a big proponent of living your life for you and to make your schedule and your life work for you and not necessarily for just medicine or the calling of medicine. And part of that might be maybe cutting down your hours or being strategic on your schedule, maybe only doing a few hours of operating time mixed in with clinic or things like
Right.
that just to give yourself a break.
Right. Yeah, actually, this is a great strategy, and you've brought up a good point that I should probably talk more about on this podcast, which is, it's different when you're a trainee, right? Your schedule is run by someone else, and you're trying to get most of the cases done. I think the senior residents feel this the most when they're using loops and headlights because they're operating every single day with a different tending. But when
Hmm.
you are an attending, absolutely, you can adjust your workflow to help that. I've heard various urologists say they try to do like a robotic case, a cystoscopy, an open case. They try to mix up their cases because the more you do of the same, the more of that same repetitive stress you're going to put
Sure.
on your body. And so, that's a great strategy that you mentioned if you can kind of do half a day of cases and then, go on do clinic. The thing that you mentioned about the loops, I was smiling kind of internally because I think this last podcast that we just aired, I actually spoke with one of our neurosurgery colleagues, and he had the same thing that you said. He goes, "Oh, pretty early on, I realized loops are doing bad things to my neck." Now, this is someone who takes care of other people's spines, right? And he said,
Right.
"Yeah, loops are not good." So I abandoned using loops and switched to the operating microscope where you have the built-in
Oh, sure.
magnification and the light, right? But again, it doesn't work for everybody, right? And if you do need loops, by the way, I abandoned wearing loops maybe just about now 7 years ago. And I've restarted wearing loops for some cases selectively. If you are going to wear loops and headlights, try to get the lightest ones, okay, and wear them for the least amount of time necessary. So if the work that you're doing, for example, for me, if I'm closing an incision or opening an incision or watching somebody else do that, I don't need to be wearing a loop for that, right? I can wear it only when I
Mhm.
need to dissect the nerve or the parathyroids. Because the less time you have that extra weight and non-neutral posture, then the better it is for you. And same with the headlight. So it sounds like Dr. Sheffield, you got, as you said, the not the dental light, but the brightest light, so you didn't have to wear a headlight, and you stopped wearing your loops. I must say that I've noticed that the newer loops, they're not the same kind of Galilean ones. You have kind of that really deep deflection angle, or it's
Mhm.
almost right angle, like a microscope.
Yeah, sure.
And yeah, they have gotten a lot lighter too. And so I find that that's not as distressing on my neck. I don't, and I've seen a lot of them being used in dentistry as well. Is that correct? Do you see people using deflection loops now more than like the standard Galilean loops?
I think I'm seeing a little bit more of that,
Yeah,
like online and stuff. Yeah, I think
yeah,
so.
yeah. Okay. So you talked about loops, microscopes, and you've mentioned now your physical therapist and certain exercises that they've kind of tailored to you. I should have asked this before, so I'm going to ask this now. Why did you end up going to see a physical therapist in the first place? And what do you do to maintain your strength and flexibility and physical wellness outside the OR days? I know you said you do other things, but can you specify what those are? Like, what routines have you found useful for your ergonomics?
Yeah, I actually started seeing a physical therapist for my pelvic health after having
Right,
twins and a 10-pound baby.
right. Oh, I
Um,
forgot. Yes, your little one was a little late and 10 pounds. Yes.
Yes, she was. So I will say the 10-pound baby was harder on my pelvic floor than the twins, or I'm sure it was a combined approach. But I was just finding a lot of women suffer through quality of life
Yes.
issues after having children or weight or whatever affects your pelvic floor. And if you can find a
Physical
PT
therapist.
who, a
Yeah.
physical therapist who specializes in women's care for that, then it can be really life-changing. And so I was seeking that out just for those reasons. I didn't want to feel like I was losing control of my bladder if I was jumping on the tramp with the kids or, just things
Yeah.
like that. I had really bad separation of my abdominal muscles, like 7 centimeter separation. And so I was trying to do exercises, but I was finding that maybe I was causing more harm by doing those incorrectly, etc. So that was a very interesting process, and I definitely recommend it, especially if you have had children, to get evaluated by someone who really knows. Like my OB was like, "You're fine, your Kegels are fine," but I'm glad I went and got checked because I had a lot of things to work on. But I thought it was so fascinating, even though I was going for that reason. It really helped like sink in my brain, like we really are a whole body, right? Like we're not just the face and we're not just the thyroid and like all our specialties. Sometimes we
The
get
hip
so
bone is
focused.
connected to
Yes.
the, yes.
Yeah, I would say
Yeah.
the mouth bone's connected to the body bone, but
Right.
um it was so interesting to me because when we were there, I'm like, okay, help me control my bladder better. And she's having me like breathing was like the first thing we did for a couple
Yes.
of weeks. And then we started doing things like raising my hand and breathing out and then next thing you know, you're doing all these crazy things. My husband and kids be like, "What are you doing?" And I'm like, "This is the hardest exercise I've done all day. I'm doing my physical therapy. It looks like I'm doing nothing, but it's really hard. I have to think
Seriously.
about 12 different steps and I'm doing all these things and I don't use these muscles ever." And they're even talking about how, getting your bite, your occlusion set can be the basis for the rest of your body following and getting everything back in alignment. And
Mm-hmm.
so that was just a very interesting process. So I wasn't going because of work injury or pain or anything, but I
Hmm.
do think it was very helpful. I had a lot of chronic headaches, tension headaches, neck pain, things like that. And I do think it was helpful, even just doing like core therapy for that. Go
No,
ahead.
it's okay. I asked because exactly this, right? Like, so as providers, physicians, nurses, healthcare workers, we generally are so used to putting other people's needs in front of our own, right? And it's not just the patients. It's your family member, it's your children, whatever. And we're often hesitant. There's a big stigma around like admitting that you're having pain, and God forbid you're human, and
Yeah.
your body reacts like a human. This is part of our
Mm-hmm.
culture issue.
Mm-hmm. Mm-hmm.
And so, just to kind of admit, listen, I don't feel right and I need to go see someone. And it doesn't matter whether you see a physical therapist, occupational therapist, someone, a personal trainer, someone who can kind of evaluate your entire body. And there are going to be imbalances, right? Muscle imbalances are part and parcel of life. We start as children, we fall down, we might hurt something, and there's an imbalance. And this thing we talk about, forward head posture for all of us,
Mm-hmm.
working in the OR and even, using our phones outside the OR or computers outside the OR, there is a tendency for the anterior chest muscles to be tight, the posterior neck muscles to be weak. Same thing happens in the pelvic area, and so you have an upper cross and a lower cross syndrome, and everyone has different imbalances depending on how you stand, how you sit,
Right.
how you work. And so just having somebody take a look and help you address those things, I think it has twofold. Well, one, physical therapy definitely helps with pain and other things and strengthening, but two, it increases your awareness of these things, right? So that when
Hmm.
you're not in those, when you are in those non-neutral position, it reminds you that you don't have to be there. You've got to come back to your
Right.
neutral position. So I think I'm so glad that you mentioned it's not like you were having all these issues, but you sought them out because they are specialists in body movement and people seek us out for our expertise. So I don't know why we're so shy about seeking out these things. So
Hmm.
I do think that that's a huge part of our culture that, we can address.
Definitely.
Yeah. And then it kind of brings me to something else that you said, which is, you said you have these authentic conversations and, I follow your podcast and I've watched a few episodes. And yes, it is unfiltered. So I'm going to ask, almost any study you read on surgical ergonomics or procedural ergonomics, women are disproportionately affected by MSK issues. And it's probably multifactorial. We are built differently
Hmm.
in terms of upper body strength, and women are generally going to be on the shorter end of the spectrum with smaller hands, etc. And the instrumentation wasn't designed for us. Does this apply to dentistry and OMFS as well? Do you find that is an issue?
Definitely. One of the biggest things for me, I mean, just in the OR, the
Hmm.
surgical table doesn't come down as far as I want it to much of the time.
Mm, yep,
And
yep,
so, or especially if you're operating with a colleague who's probably a male, because it's a male dominated field, who's probably a little bit taller than me, then
or a
you,
lot, or a lot.
right, or like my husband, who's
I was just thinking of age, by the way.
six
So yeah,
three.
yeah,
He has the opposite problem. He's so accommodating that he's like bending over.
right,
But so
right.
then you're up on a stool, and maybe they have like ergonomic pads and things like that on the floor, but they don't have those on the stools, things like that. Or you can't move over as well when there's a stool that you have to follow with. So that in the OR is definitely, but even in my clinic, getting a surgical chair or a dental chair that goes down low enough where I need it and want it to
I
be,
see.
the tools are definitely made for men. So even just a simple one would be my injection syringe, that
Uh-huh, uh-huh.
dental injection syringe everyone fears. You got to pull back with your thumb so that you can aspirate, make sure you're not injecting into the blood vessel. And you're supposed to do that every time you inject. And those are made for male hands. And so sometimes even something as simple as that is difficult for women to use. So
Mm.
it definitely plays into our field as well.
Wow, that's so interesting. I do fear that needle. I usually close my
I
eyes if I need
know.
that needle. So, but your point is well noted and taken because I was speaking to a bunch of GI docs and nurses about sort of the differences in how a 6.5 hand female hand has to hold a colonoscope as opposed to sort of a size 8 glove
Oh,
male
sure.
hand. And it's exactly right. Like we need two hands for the dials, whereas the men can turn the way the dials are with one hand, right? We can hardly reach the dial, and so that you have to put special attachments and things. So I wonder, is there any discussion with industry, on the ones making dental equipment and things like that, to address this kind of, well, it's almost an issue of, it's an inequality if it was, so
Hmm.
how has that kind of come up in sort of maybe the dental conferences or dental meetings that you've been at? Or has it
Not
come up?
not as much as I would like. I mean, I've
Mhm.
seen little things. I think one of the reasons I thought about the syringe being off is that I've
Yeah.
seen them advertise like, here's the pink one type of thing.
Oh,
I don't know if
really?
it's
Okay.
necessarily pink, but
Yeah, but yeah,
here's the
yeah.
one for the women.
Smaller-handed surgeons. Yeah.
Yeah, exactly. I was happy to see just this last annual meeting that I went to last month that there was a headlight company that made a headlight that actually made a space for a ponytail.
Oh,
And
wow.
I thought,
Okay.
oh my gosh, you need to come and be at our retreat. And we need to just the
Yes,
fact that you
yes.
like cared enough, because that seems like a dumb thing. Like,
Yeah.
oh, ponytail, make it work. But like my friend just the week before was like, I'm looking for a headlight, but when I wear my headlight, I have to put my like I have to do this weird, like split in half, funny, really weird
Mm,
thing with my
mm,
hair, and
mm.
that, of course, if you got your hair kind of bunched up or scrunched in the wrong spot, that can cause some pain or discomfort too, besides just being kind of awkward, but I guess it doesn't happen enough that I was very impressed. Like, wow, thank you. Thank you so much for like taking our feedback and taking it seriously and solving a problem.
Good to know. Good to know. I also want to talk about something else you mentioned, which was kind of those anti-fatigue mats. And I'm glad you brought them up because I'm trying to think. I think most dentists I've seen, they're usually able to sit right in a chair and then do their work. And I'm glad that, some of your OMFS cases are amenable to that as well. Anti-fatigue mats, they do make them for the floor, and there are actually, this is not the first time I've heard, the issue with the stool. So I think there's just a misconception out there. There are smaller ones that fit on top of the stools, and you can sometimes get stools that are actually, come already pre-made with the anti-fatigue mats
Oh,
on them. So
nice.
there are ones that are, just because you're using a stool or two, it doesn't mean that you can't have an anti-fatigue mat.
So how do you propose as a surgeon talking
Yeah.
to your facility to encourage them to maybe spring for things like that? Have you found that people are running into that? Like, here are things that are helpful for us. Are they prioritizing the health of the doctors, or is that, a pain point?
Now, listeners, I just want you to realize what happened, okay? The podcast host flip has been flipped, and now apparently I am in the hot seat on
Oh
Erin's
no.
podcast. This is no longer the surgical ergonomics podcast. Anyway, but challenge accepted, Erin. That is a fantastic question because when we talk about these things, the first thing is to make our, I think, surgeons, proceduralists, staff, nurses, scrub nurses all aware that these are options, right? And then in my experience and in the experience of others in that new society of surgical ergonomics that you've seen me talk about, is this thing that if you actually bring it to OR administration committees, for example, usually every place has a surgical services subcommittee, which has all the key stakeholders, right? Anesthesiologists, nursing staff, and surgeons. And I found that most people are appalled to find that surgeons are actually having trouble with their instruments and are in pain. And once you bring some awareness, there is willingness to make some changes as long as there is evidence. So, in the grand scheme of things, if you think about all the equipment you purchase for a hospital, and I'll come to a small practice next, but if you think about all the equipment, anti-fatigue mats are relatively cheap
Yeah,
intervention and they've been
for
shown to
sure.
have benefits. So that's pretty easy to do. Then things like changing all the headlights available in the operating room, for example. I've seen institutions do invest in that, including my own. Now it takes a long time because, everything is got to be approved and budgets and this and that. But I think bringing awareness there is a good place to start. I think it will take a long time before that becomes part of ordinary practice because
Mhm.
we don't complain. Healthcare workers don't complain, right?
Right.
It's
Oh,
trying,
for sure.
we, like you said, we contort ourselves to take care of the patient. We make do. And so as long as we keep doing that, nothing will change. But if we ask for these things, I see that the needle will move. Maybe not fast enough, but it will move. Now, what happens if it's a small private practice? It's not a big institution, right? Then again, I think in a similar way, if you decide that that is part of your practice policy, that there will be preservation of physical and mental well-being, and many practices do that, then these are kind of small investments. If you're going to invest in a big $1 million+ robot, for example, for your small hospital or your practice, let's say whatever dental equipment, latest fancy thing you wanted, then you've got to make sure that you buy the proper chair for that equipment too, and not be sitting on some random stool, just like we sit, at the robot on this random stool, because then the ergonomic benefit of the robot is for nothing because you're now dealing with an uncomfortable chair and getting MSK symptoms from sitting awkwardly in that chair. So I think as long as there is an understanding of that being kind of a goal, certainly there is more openness to listening and doing these things.
Oh, thank you. You
Okay.
did good. You
Okay.
can take the
So,
reins back. Sorry about
okay, do I
that.
get my podcast back now? All
Yeah,
right.
it's yours
Okay.
again.
All right. Okay. Well, so, these conversations always go so quickly. So I think we just have a couple of minutes and we'll wrap up. In these last few minutes, what advice would you like to give for your DDS OMFS trainees or any surgical trainee for that matter from your side, the things that you focus on in your podcast? Times have changed from when you and I trained. So, what advice do you give them for maintaining their well-being, both mental and physical?
Ooh, to narrow down to like one thing. I think the biggest thing, and we kind of hinted at this already, is that you have to live your life for you. When
Hmm.
you're a trainee, you're not in control. I
Yes,
always joke because
yes,
they
yeah,
own you. You
yeah,
don't. You have
yeah,
very little autonomy or decision-making capacity, et cetera. And it's kind of a hard transition after a residency to go from that to being like the boss of you. And I think it's easy to have taken the messages that you received and really burn them into your psyche, for example, like what professionalism is. Like
yeah,
one of my big soapboxes is just these ideas of what is professional. A lot of times is I think kind of old fashioned or male dominated, etc. And that, really doesn't matter. We want to be professional. Of course we do, but like doesn't matter if you have natural hair, like that makes you
right,
unprofessional. If you have different,
right,
coarse hair or just dumb things like that. This idea that you have to give your whole life to deserve to be in this specialty or whatever. I don't buy that because I think it sounds noble and it sounds very self-sacrificing, but when you give too much, you don't have enough in the tank to really give back. And so I
correct,
think if you can be your best authentic self, that's the best thing we can have to offer our patients.
right,
And
agreed.
that's going to be different for everyone. So maybe for someone like me, I'm a crier. I might cry when we talk about your cancer diagnosis. And since that's me being authentic to me, I think most of the patients are going to appreciate that and feel that that's coming from a place of love. Now, if you're someone that's a little more stoic and that's not you're not an emotional type person and you do that, then they might sense that it's inappropriate and it feels forced. So you have to
Right,
do what's right to you. But I think try to just make those decisions that make you happy, that make you the best person you can be. Because when you're being the best person you can be, you're going to be the best doctor as well.
live an authentic, joyful life.
Yes,
Right. Well said. With that, I think it's time for us to wrap up this podcast, but I do want to take a moment to again express my most grateful thanks to you again for being here and sharing your perspectives on the profession, ergonomics, the culture, and giving me a chance to catch up with you and your life.
definitely. I love what you're doing. Thank you so much.
Please remember to subscribe to the podcast and follow us on social media: Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening. To enter your name for the Ergo Angle Deflection Loops and Headlight Combo giveaway, please go to our podcast landing page at www.surgicalergonomics.com/podcast/ and fill out the contact form at the bottom of the page. Choose Other in the drop-down menu and indicate Loops giveaway in the message. We will do a drawing for the winner in December of 2025, so please spread the word among your colleagues and friends who might be in the market for new loops. Thank you.